So, good evening, all, and welcome to this recall session on infectious diseases on the questions that appeared in the NEET SS 2025 examination. I'll begin with a disclaimer. Most of these questions are questions that were discussed by students with me. So, there can be errors in the stems as well as in the options, but overall, what the examiners intended by the questions, that is what I would like to discuss. So there may be some of the options you may see that they may not be the correct options that were discussed, but overall I think you will get what the correct answer was. So that's the intention. So I have modified some of these questions and slightly they may be different from what you have actually seen in the examination. And do let me know in the comments how the exam was. I mean the infectious diseases part in particular. I could gather 12 questions related to infectious diseases. If there are more questions, again, you can comment it in the comment box and we can discuss that as well. So, there was this question, which was a 26-year-old primate gravida at 10 weeks of gestation found to have toxoplasma IgM positive and IgG negative. And the patient was asymptomatic. What is the most appropriate treatment at this stage? So, the options included pyrimethamine, sulfadiazine plus polinic acid, spiramycin, clindamycin plus leucovorin, and termination of pregnancy. These were the options. So the treatment of toxoplasmosis in pregnancy depends upon the stage of pregnancy. The first thing, if a woman wishes to terminate the pregnancy, that will be the option. So that will entirely depend upon the wish of the patient. But the appropriate treatment, if it is asked, it will depend upon the stage of pregnancy. So if it is a first trimester, and it's an acute infection, the goal of treatment is to prevent the vertical transmission. The drug of choice here will be spiramycin. If it's more than 14 weeks or the fetus has a confirmed infection, basically you're treating the fetus, there the treatment will be pyrimethamine plus sulfadiazine plus folinic acid. If that is not available, you can use trimethoprim plus sulfamethoxazole. So the answer here will be spiramycin. So this will be the correct answer. So basically, the antifolate drugs are again contraindicated in the first trimester of pregnancy, and spiramycin is considered as a drug of choice for treating acute toxoplasmosis in pregnancy in the first trimester. So that's the answer there. Question number 2: a post-renal transplant recipient presents with symptoms suggestive of end organ involvement. I'm not sure what exactly was the symptoms. It could be a GI or a pneumonitis. A tissue biopsy was performed, and what is considered as the confirmatory test for the diagnosis of tissue invasive CMV disease. Overall, this is what the examiners wanted. That's what I believe. So you have a qPCR blood, a CMV antigen, ISC versus a CMV antigen on tissue biopsy or CMV serology. And you may also have seen this image also. I'm not very sure if the image was shown. Like the image is basically, it shows cytomegalic cells. This is basically that of a CMV pneumonitis. So you can see large cells, cytomegalic cells with an owl-eye nucleus, which is very typical of CMV pneumonitis. So whatever is the situation, if you have a tissue invasive disease, the diagnosis is not based upon the blood PCR. The blood can have CMV viremia even without a tissue invasive disease. If you have to prove that the patient has a tissue invasive disease like a pneumonitis or a colitis, you have to take the tissue, demonstrate the cytomegalic cells as well as the owl-eye inclusions, but that sometimes may not be, it's not very sensitive. And the test of choice here will be immunohistochemistry for CMV antigens on the tissue biopsy. So that will be the correct answer. It's not a DNA PCR. DNA PCR you do while you're monitoring for CMV reactivation, but not for the diagnosis of a tissue invasive disease. So that is the question number 2. So question number 3 is a patient present with chronic fever, cough, and weight loss. A chest X-ray reveals bilateral infiltrate for the cavity lesion, clinically mimicking tuberculosis. Sputum microscopy shows gram-negative bacilli with a typical safety pin appearance, bipolar staining. What is the most appropriate treatment? I'm sure the options, only one of the options may be the correct, like in the options that were asked in the exam. Streptomycin plus doxy, ceftazidime followed by cotrimoxazole, rifampicin, clarithromycin, butyl afoxatracin with B plus itraconazole. Basically, so you have a cavity lesion and a safety pin appearance with bipolar staining. Is basically this is the bipolar staining. I don't know if the image was given in the exam. This is a slightly modified age generated image. Like you not see very typical safety pin appearance, but this overall this is what you see. In any case, this history is suggestive of milioidosis. So if you have a cavitary lesions and you're typically seeing gram-negative bacilli, which has a safety pin appearance, it is suggestive of milioidosis. And the treatment options for milioidosis, it actually contains two phases, as you all know. There is a intensive phase, which is initially. So in the intensive phase, you can either use ceftazidime, or if the patient has severe disease or the patient have neurological involvement, etc., meropenem can be used. Now, this is followed by a prolonged eradication phase so that the disease does not recur. And there, the agent of choice is trimethoprim, sulfamethoxazole, or cotrimoxazole. So the answer here will be ceftazidime, which is followed by cotrimoxazole. So that's the correct answer there. So question number 4. A female patient presents with tender regional lymphadenopathy and mild hepatomegaly. She provides a history of being scratched by her pet cat a few weeks prior. A diagnosis of cat scratch disease is suspected. So what is the most appropriate antibiotics of choice? See the options: azithromycin, ceftriaxone, ciprofloxacin. There is no treatment which is self-limiting. This is the options which are given. So basically, I believe this patient has regional lymphadenopathy as well as mild hepatomegaly. So whenever you have a case of cat scratch disease, now this is cat scratch disease, so you have to consider whether it's a typical or atypical cat scratch disease. Now, typical cat scratch disease refers to wherever you get the scratch, there will be a papillar lesion and there will be regional lymphadenopathy also. So that's typical cat scratch. Atypical cat scratch disease refers to other manifestations of cat scratch disease, which includes the Perinaud's oculoglandular syndrome, hepatosplenic disease, like in this patient, neuroretinitis, other neurological manifestations like meningitis, encephalitis, prolonged fever, like FU-like presentation, pneumonitis. Any of them will be taken as an atypical cat scratch. So any of them is there you are supposed to treat actually. Atypical cat scratch may require treatment. Now the treatment options for typical cat scratch disease, routinely typical cat scratch disease does not require any treatment. If you have just a papillar lesion and a cervical lymphadenopathy, you need not treat at all. If you have an extensive lymphadenopathy, you may treat it with azithromycin. Now, if you have neuroretinitis or you have other manifestations of atypical cat scratch disease, there Harrison mentioned the treatment of choice will be doxycycline plus rifampicin. Okay. Other atypical cat scratch disease you already mentioned, like the Perinaud's oculoglandular syndrome, you have other neurological manifestation, hepatosplenomegaly, etc. Same as neuroretinitis, doxycycline plus rifampicin. An alternative option will be azithromycin plus rifampicin also. So basically, typical cat scratch disease do not require treatment. Atypical manifestation require treatment. Treatment options for atypical disease includes doxycycline plus rifampicin or azithromycin plus rifampicin. Now, I'm not very sure about the options that were given. If this was it, azithromycin was given as the option, that's the answer. But if doxy plus rifampicin was given as the answer, like when the option was there, I believe that could be the answer. I'm not very sure if that option was not there. I only was told that azithromycin was there in the option. So azithromycin will be in the answer. This is like, it is like this. But if it is an atypical cat scratch disease and doxy plus rifampicin were given as the choices, I'll go for that actually. So that is it. Now there is another question: an adult male with regional lymphadenopathy following a history of cat scratch, a lymph node biopsy was performed which revealed stellate granuloma. Which of the following is true regarding the management of natural history of the disease? So there is, like, it is self-limiting disease, and azithromycin reduces the duration of lymphadenopathy. Surgical excision is the treatment of choice to prevent sinus formation. Bacillary antiemetosis is primarily seen in immunocompetent patients. Intravenous antibiotics are required in all cases to prevent dissemination. Again, options. Some of these options may not be the exact one. Basically, if you have a regional lymphadenopathy in a patient with cascade disease, it's basically self-limited disease. Even if you have neuroretinitis, like many of the times you can even choose not to treat, and it is self-limiting, but azithromycin reduces the duration of lymphadenopathy. So if that is the option there, like, that will be the correct option. Surgical excision is only for the diagnosis, actually it's not a treatment. And bacillary angiomatosis is another manifestation of Bartonella infection, and it is usually seen in immunocompromised, especially advanced HIV. Antibiotics for castrate disease are usually given as oral, so the answer here will be 4. The A, actually, answer will be A. Question number 6 is a patient present with HIV infection who presents to the clinic and is found to have persistent oral candidiasis, and further evaluation reveals pulmonary tuberculosis belongs to which WHO staging of HIV/AIDS? Stage 1, 2, 3, or 4? So basically, that's a straightforward question from the WHO classification. So if you have a stage 3, you can see that persistent oral candidiasis is a stage 3 disease. Similarly, pulmonary tuberculosis is also a stage 3 disease. So both are clinical stage 3, so there is no confusion in that question. Answer is stage 3. Question number 7. A young patient presents with fever, sore throat, and lymphadenopathy. Pulmonary test is positive. Patient is hemodynamically stable, maintaining oral intake, and has no evidence of airway compromise or severe hematological complications. This is why I understood from the questions. Options. So what basically they're asking the treatment. So basically options included oral acyclovir, intravenous corticosteroids, antibiotics, or conservative or symptomatic management. And some of the students are told that they were given the image also of atypical lymphocytes. Basically, these are T lymphocytes which act like became reactive lymphocytes in response to the antigenic stimulation. So this was IMN. So IMN basically is a self-limiting disease. So most of the patient, majority of the patient do not require any particular treatment. There is supportive treatment, rest, hydration, analgesics or antipyretics if needed. You also will advise them to restrict the activity because there is a theoretical risk of splenic rupture in the first 1 month. Now, there are certain patients who may require steroids. That are patients who have impending airway obstruction due to the large tonsillar enlargement as well as the large lymph node. Sometimes their airway may be compromised. So that is one situation where you will have to give steroids. Autoimmune hemolytic anemia, severe thrombocytopenia, hemophagocytosis, lymphohistiocytosis, severe CNS or cardiac involvement. These are the indications for steroids in a patient with IMN. Our patient did not have any of this, is what I believe. Acyclovir, they have studied the role of acyclovir. There is no role. Routinely, steroids are not indicated. It will increase the risk of bacterial infections. But if you have these conditions, you can give steroids. So the answer here will be conservative or symptomatic management. So question number 8 is a 32-year-old man present with 7 days history of fever, myalgia and sweats. Blood culture receives a negative coccobacilli, which is oxidase positive. Serum agglutination test, I think they have mentioned it as brucella, and is 1 in 320. And what is the best treatment? See, the option included doxycycline alone for 6 weeks, ciprofloxacin plus doxycycline for 6 weeks, ciprofloxacin plus streptomycin for 6 weeks, or doxy plus streptomycin for 6 weeks. So the answer, this is basically a brucellosis. You call it as a non-focal case of brucellosis, which means that there is no definite foci of infection, it's just present with fever. So such situation, the treatment of choice is streptomycin or gentamicin. If gentamicin is there, that becomes a drug of choice. Gentamicin plus doxycycline. Either strepto or gentamicin can be used. Nowadays, gentamicin is more preferred over streptomycin. So the answer here will be doxy plus streptomycin for 6 weeks. So that's the answer. There's a question number 9. There's a patient with multiple sclerosis is being considered for treatment with natalizumab. To stratify the risk of developing progressive multifocal leukoencephalopathy and rule out latent infection, a screening test is required before initiation. Which of the following is recommended as a screening test to assess the risk of PML? So the option included Jesse virus in the CSF, Jesse virus PCR in the serum, anti-Jesse virus antibody in the serum, or anti-Jesse virus antibody in the CSF. So basically, you have to understand that they are not asking for a diagnosis of PML. So if it was say a patient on natalizumab developed some neurological manifestation and you want to diagnose PML, so the answer will be you have to demonstrate the JC virus DNA PCR in the CSF. But here that is not the question. You're planning to start on natalizumab, and how do you risk stratify the patient? Whether they will develop the PML, what is the risk that they will develop PML? So basically, though it's an infectious disease question, the answer comes from this neurology table in the treatment of multiple sclerosis. and there are a table which describes various options for multiple sclerosis. So natalizumab, so the major risk is PML. So 0.4% can develop PML, but it can be given safely only if the serum antibodies to JC virus are absent. So what test will you do? The serum antibodies to JC virus. And even if it's negative initially, you have to repeat the JC virus antibody every 6 months so that they can even later acquire it and later develop PML. So the answer here is very clear. So it will be anti-JC virus antibody in the serum ELISA test. Question number 10. An HIV patient with CD4 count of 25 cells per millimeter cube presents blurred vision, flutters in the right eye. Fundoscopy reveals large areas hemorrhage and exudates, and is consistent with CMV retinitis. So the options included high dose steroids plus immediate initiation of ART, intravitreal ganciclovir, systemic valganciclovir, immediate initiation of ART alone, or intravitreal steroids or a systemic acyclovir. So basically, this is a case of CMV retinitis in advanced HIV patient. And the treatment options for a patient with CMV retinitis include oral valganciclovir. If it is vision threatening, you can use IV ganciclovir or IV foscarnet. And along with that, you will also give local therapy if the disease is limited to the eye with intravitreal ganciclovir also. So the usual duration of treatment is around 3 weeks, and then you continue as a maintenance period of oral valganciclovir. And you continue until the CD4 is more than 100 per microliter, which is maintained for a period of at least 6 months. So if you look at this options here, the option will be intravitreal ganciclovir and systemic valganciclovir. Even if it's systemic ganciclovir, that's also correct answer, depending upon the vision threatening. Sometimes a vision threatening disease, we start with IV valgan and then along with intravitreal ganciclovir. Oral valganciclovir plus intravitreal ganciclovir is also an option. So the answer here will be this B. Question number 11. Which of the following statement regarding isoniazid and induced hepatotoxicity is true? Again, I'm not very sure about the options. I believe some of these are correct. It typically presents as a cholestatic pattern. That is not correct. Isoniazid usually causes transaminitis alone. There is ALT, AST will increase. The bilirubin is not affected. Alkaline phosphatase or GGT are not elevated. Rifampicin can cause a cholestatic phase. So this is a wrong statement. Mild asymptomatic elevation of AST elevation is common and does not require stopping of the drug, which is true. This is called as hepatic adaptation. So many of these patients can develop mild elevation of transaminitis. It's not like you just have to stop the drugs immediately. You can continue that. So that's a correct choice. If there is a mild elevation of AST-ALT, the drug must be stopped immediately. I'm sure that both of these options may not be there, but that is not correct actually. I mean, if it is less than 3 times the upper limit of normal and the patient is asymptomatic, you don't have to stop it. It is invariably associated with fever, rash, and eosinophilia. No, not all cases. Most of these cases, they just present with hepatitis alone. So, isoniazid hepatitis is discussed again in Harrison. So, basically, only 0.1% of patients who are treated with isoniazid develop hepatitis. But fulminant hepatitis can develop in around less than 0.01% of the patient. It is an idiosyncratic reaction, but there is an increased risk in patients who have an advanced age. There is daily alcohol consumption, or women within 3 months of postpartum. So these are the risk groups associated with INH, like associated with an increased risk of INH-related hepatitis. So INH-related hepatitis, if it is asymptomatic, it is quite common that there is no need to discontinue. But you will stop INH if there is symptoms of hepatitis and AST or ALT is more than 3 times the upper limit of normal, or if the AST ALT is more than 5 times the upper limit of normal, even if the patient is asymptomatic, you have to stop ANH. So again, as I said, I'm not very sure of the options, but the crux is that if it's a mild transaminitis less than 3 times the upper limit of normal, there is no need to stop INH. It is not a cholestatic pattern, it is pure transaminitis that you usually see in INH. And again, as we have already told, hepatic adaptation is common, idiosyncratic reaction, and the risk is associated with an increased age, early postpartum period within 3 months, and daily alcohols. So that is regarding that topic. And the final question, again, I'm not very sure about this question also, but I believe something like this was asked. A 24-year-old male with confirmed dengue fever present with on day 7 of illness with persistent high-grade fever On examination, he has hepatosplenomegaly and pallor. Hemodynamically stable but appears toxic. Laboratory investigation shows a low hemoglobin, low total count, a platelet was 18,000, AST 450, LT 120, serum ferritin is 16,500, triglycerides 410. So, which of the following is the most likely diagnosis? So, dengue shock syndrome, very unlikely, there is no shock as such. Hemophagocytosis, lymphohistiocytosis, possible. Expanded dengue syndrome, fulminant hepatic failure, not fulminant hepatic failure, there is just my like moderate transaminitis, INR is not given. DIC again, INR and APTT is not given, it's difficult to say. But basically, they were intending regarding hemophagocytosis, lymphohistiocytosis. So, any infectious diseases condition, when there is a prolonged fever, transaminitis, elevated triglycerides, as well as ferritin with bicytopenia, you think the possibility of hemophagocytic lymphohistiocytosis or secondary HLH. So, secondary HLH, basically there is a 2024 criteria, the previous criteria has been revised. So, there is fever is one of the criteria, splenomegaly, and then you have bicytopenia, that is either hemoglobin, platelet or neutrophils, at least two of these cell lines are reduced. Hyperfibrinogenemia or triglycerides are elevated. Hyperferritinemia, that is like more than 500, and bone marrow shows hemophagocytosis. That's only one of the criteria. Just because the bone marrow shows hemophagocytosis, it doesn't mean it's always HLH. All the other criteria need to fulfill. And elevated soluble CD25 or soluble interleukin 2 receptor alpha. And there are levels, cutoffs also given. You have to remember that. But if a patient fulfills the 5 criteria, you can call it as HLH. So, our patient has fever, the patient has splenomegaly, the patient has bicytopenia, hyperferritinemia. So, this answer here will be hemophagocytic lymphohistiocytosis or HLH. So, these were the 12 questions that were asked in the infectious diseases part. Please let me know in the comments, like, how did you find the exam? And also let me know, like, I believe that all the questions were actually discussed in our videos. And please let me know about the feedbacks about the videos as well as the DocTutorials, GT, as well as the MCQ exams that you have done. And how did it help you in basically answering the questions? Thank you all for joining. Good night. 1 minute, I'll just see if there are any comments in the live chat. So, good evening all. Welcome to this. Anyway, thank you. Please, I will answer any of these comments. I can just type in and I will type the answers also. Good night all. Bye.